It's great honor to be able to speak to you today. I'd like to talk about practice test and applicability of quality indicators for low-risk labor care in Japan. Background. In the world, annual childbirths were about 140 million, according to the 2017 UNICEF report. In low-risk labor, death and complications of mothers or infants are rare. But low-risk labor can suddenly shift to be high-risk. Low-risk labor care needs constantly monitoring and quality improvement. Previous indicators mixed high and low labor care. They hardly included patient point of view. There are methodological and systematic issues on development, practice test, and real measurement. Therefore, previous indicators are not useful for and not applicable in Japan. We developed the 35 quality indicators for low-risk labor care in Japan based on recommendations of clinical practice guidelines and existing quality indicators using the modified Delphi method in 2012. They are developed by panel including clinicians and lay mothers. The goal was and is to co-create quality improvement between patients and professional staffs. The quality indicators for low-risk labor care had not been tested so far. Objective. The aim of this study is to demonstrate the applicability of quality indicators for low-risk labor care in Japan. Method. In this study, the definition of low-risk labor is pregnancy with no special high-risk factor or complications. This study design is a cross-sectional study by retrospective medical record reviews. Setting. From the panel member of development of indicators to hospitals. As an average and suitable hospital for this test are introduced. They consented in the survey. The two hospitals have a perinatal medical center in urban or suburban area of Japan. A perinatal center is a key facility for perinatal care and management of the emergencies in prenatal and postnatal care. Participants. The target persons were mothers admitted for labor and delivery between 1st of April 2015 and 31st of March 2016 in the two hospitals. The participants were recruited from mothers meeting the eligibility criteria. The inclusion criteria were mothers who opted for delivery in a midwifery ward and who were judged as low-risk labor during the second trimester. Exclusion criteria were the following. mothers who were pregnant with special high-risk factors and complications, who didn't admit for labor and delivery in a midwifery ward for any reason, or who rejected the participation of this study. All participants consented in taking the survey. For assessment of the reliability, we randomly selected sample records consisting of over 10% of total participant records. Variables. We calculated the percentage for each indicator as shown in this slide. Of mothers meeting an eligibility criterion, mother receiving a suitable care, or reaching a desired outcome. We calculated individual indicator score using dichotomous variable with a value 0 or 1 for each mother and for each indicator. We applied the practice test of applicability from the three criteria of improvement potential, feasibility, and reliability. Improvement potential is the sensitivity to detect when medical performance has changed in order to discriminate between and within subjects. Low improvement potential is the percentage of an indicator score more than or equal to 19%. Feasibility is the extent to which the required data is easily available or could be collected without overburden for the staff. Unfeasible is a percentage of missing data per an indicator score, more than 25%. Reliability is how well the measure is defined and how precisely it is specified so that it can be consistently implemented by either same or different data collector. We assessed the intra-rater and inter-rater reliability of data collection with more than 1 month in between. We randomly sampled 40 mother records from each of 2 hospitals and calculated agreement with kappa coefficient for the same indicators. In kappa coefficient, a kappa score less than 0.4 was considered to be poor reliability, and the kappa score more than 0.6 was considered to be good reliability. Data sources and measurement. 7 midwives and 1 researcher collected the data. 4 of the midwives worked in the participating hospitals. The midwives had worked for more than 3 years and received training on how to collect data for measuring indicators. They manually collected the data from medical record and entered it into REDCap. The REDCap is an electronic data capture system. Sample size. This study was not specific. hypothesis testing. Considering feasibility of the collection, we planned to survey annually between 100 and 200 deliveries per participating hospital. Statistical analysis. Overall percentage of baseline characteristics and individual indicators were descriptively analyzed. We analyzed using agreement and kappa coefficient for reliability. JUMP was used for statistical analysis. This slide shows the ethics, approval, competing interest, and funding of this study. Result. Among 388 eligible participants, 347 mothers were analyzed. This slide indicates the characteristics of the participants. All characteristics show average values of low-risk childbirth in Japan. The result of improvement potential. The percentage of an indicator score more than equal to 19% is low improvement potential. Number 3, GBS positive mother received antibiotic prophylaxis during childbirth. Number 4, admission labor assessment. 2 indicators had low improvement potential. The result of feasibility. Unfeasible is a percentage of missing data per an indicator score more than 25%. Number 14, respiratory support. Number 15, necessary resuscitation. Number 26, peer review of severe adverse event. Number 28, review childbirth experience with supported midwife. Number 30, smoking cessation counseling. Number 31, 3 times administration of vitamin K by 1 month after birth. Altogether, 6 indicators were considered unfeasible. We showed the result assessed the inter-rater reliability of data collection in reliability. We show the result calculated agreement with kappa coefficient for the same indicators. Kappa score less than 0.4 was considered to be poor, and kappa score more than 0.6 was considered to be good. All indicators had an agreement score greater than 0.5. There were some indicators having low kappa score, even though high agreement scores. In intra-rater reliability, this phenomenon appeared in the QIs. Number 4, admission labor assessment. Number 6, second stage labor assessment. Number 14, respiratory support. Number 15, necessary resuscitation. Number 17, supported in the most comfortable position. Number 31, 3 times administration of vitamin K by 1 month after birth. Number 33, mothers or infants readmitted within 30 days of discharge. Altogether 7 indicators. Inter-rater reliability result. A kappa score less than 0.4 was poor, and kappa score more than 0.6 good. In inter-rater reliability, this same phenomenon appeared in the QIs number 4, number 5, number 6, number 14, number 31, altogether 5 indicators. Discussion. Using retrospective medical records review, we assessed applicability of 35 quality indicators of low-risk labor according to improvement potential, feasibility, and reliability. High improvement potential was 33 of 35 indicators. High feasibility was 29 of 35 indicators. There are generally good inter-rater and inter-rater reliability. The present practice test with some cautions supported applicability of the quality indicator set for low-risk labor care in Japan. Practice test before applying in reality are highly desirable to identify issues for utilization of indicators. The reason of 2 indicators with low improvement potential was routine practice. We consider this phenomenon as ceiling effect. Ceiling effect indicates that the indicator scores are near their maximum value. If ceiling effect occurs, it is difficult to evaluate quality improvement or detect differences between the measured score over time and other hospitals. The reason of 6 indicators with unfeasibility was no record existed. First, retrospective collected data from medical records. Second, existing formats of medical records such as a clinical pathway. If we prospectively measure indicators using an electronic data capture system, we will minimize missing and ambiguous data scores. This result showed that we need to provide a more reliable prospective data collection. Some indicators had high agreement score and low kappa score. We suspected the 2 following reasons. First was difficulty in finding the required data from various medical records, digital and paper. Second was composite measures combining 2 or more components, for example, each of which individually reflects into a single performance measure as a quality of care. Limitation. First, the setting was limited to only 2 hospitals with a perinatal medical center. 2 hospitals had sufficient medical facilities and staff. If necessary, emergency care for high-risk labor is immediately provided by obstetricians in the same hospital. Their characteristics may have an effect on these measuring results. Second, the quality indicator set itself was tested in Japan and cannot be used in other countries without being adapted. However, the process used for the practice test provided to be valid and transparent and could be useful in other countries. Third, we assessed only part of applicability from 3 criteria of improvement potential, feasibility, and reliability. We didn't test the other minimal criteria as accessibility and predictive validity. Conclusion. Our 35 quality indicators for low-risk labor care showed to be applicable in general. The quality indicator set can be widely, with caution, be implemented for real clinical practice. Thank you for listening to our presentation.